Hi guys, welcome to the second in my series of skill videos. In this one we'll be looking at anaesthesia planning, rapid sequence induction and endotracheal intubation, as well as a note on waveform capnography. So what are these things and why do we do them? Well, RSI, or rapid sequence induction, interchangeably rapid sequence intubation, is the process of using medications in a rapid sequence to sedate and paralyse someone to allow for intubation. And this is done in patients who require a definitive airway but are just too awake to be successfully tubed as they are. So these might be patients with a combative head injury, for example, or some airway burns that you predict to deteriorate. Anaesthesia planning is the process of not only deciding the tools that we're going to use to affect this RSI, but also deciding on contingencies that we will take should we encounter any failures along the way in our process. We have to recognise that RSI is inherently dangerous, and planning is the only way that we can begin to mitigate some of the risks of this procedure. If we fail to plan, we also leave ourselves without options if things go wrong. And when we're talking about removing the patient's ability to breathe for themselves, the result of failure is obviously catastrophic. So here we have a patient with a head injury. This patient's combative, and we've decided that they need to be intubated. So we're going to have to come up with a plan to anaesthetise them and to intubate them safely. So this is the Queensland ambulance procedure for RSI, even though it is mistitled. This one's good because it contains a handy checklist which we can work through. So first of all, we're going to assign some roles within the group. Ideally, we would have at least 3 clinicians. One will be the overseer. Another one will be the airway clinician, and the third person will be the circulation clinician, who will deal with medications and such.
So following our RSI checklist, our first step is going to be to pre-oxygenate our patient. In this patient who's spontaneously breathing, I find it will be easiest to run a nasal cannula at 15 litres per minute. In someone who is unconscious, you would still run the nasal cannula, but you would ventilate with a bag valve mask over the top of that. The idea being to wash out as much nitrogen as we can from the lungs and replace it with oxygen. This gives us a bit more time to play with during the apneic period.
Next, we'll ensure that our patient is fully monitored, including blood pressure, cardiac rhythm, SpO2 and end-tidal CO2 ready to go connected to our bag valve mask. We'll also ensure that we have patent IV access and that we've got fluids running. While the patient's pre-oxygenating, we're going to perform an equipment check. Firstly, we'll ensure that we've got suction located somewhere easy to get and that it's been tested. We'll confirm that our bag valve mask has the end-tidal CO2 connected to the circuit. We'll keep a selection of airways, oropharyngeal, nasopharyngeal and supraglottic, and we'll keep 2 sizes of each just in case one doesn't fit. We have a laryngoscope with 2 blades for the same reason, one slightly smaller. The bulb's been checked on the laryngoscope as well. 2 different size tubes in case the first one doesn't fit. A bougie, which is preloaded into the tube that I'm intending to use. Some tube tie, a stylet in case it's required. McGill's forceps, just in case we encounter any obstructions that we weren't expecting. And a capnogram, which plugs on the end just in case our end-tidal CO2 fails. Ambulance Tasmania, we use a needle crike kit for an emergency airway. So I've got that here. The preference would, in an adult patient, be an open crike. We'll then ensure our patient is positioned in such a way that will give us the best chance of getting that great view on the first attempt, as well as our equipment placed where we need that to be for ease of access. From there, we'll prepare our drugs that we're going to use for sedation and paralysis. So when we're considering those medications, we have to also consider the phases of anaesthesia. Primarily our concern will be the induction and maintenance of anaesthesia in this person who we're about to RSI, but we do also need to be mindful that they may begin to emerge from that anaesthesia at some point. And in any case, the goal at each stage is to keep the person unconscious, keep them free from pain and paralysed or unable to move. And during the induction phase, which is what we're primarily covering, there's a sequence in which we administer these medications. Firstly, I think it's probably fair to give an analgesic because it takes some time for that to work, and if we can get that on board early, that's probably better. Secondly, we'll provide a sedative, so we'll render the person amnesic. We can choose either midazolam or something like ketamine, which also has the benefit of being an analgesic in its own right. And thirdly, we'll provide paralysis so that the person's not able to gag on our tube or to fight. And the standard is becoming rocuronium. Succinylcholine is another option that some services use. We've considered the medications that are available to us, and we've decided to run with ketamine and rocuronium for the induction of our combative head injury. So now we'll run through the process of physically placing the tube. With our analgesic and our sedative on board, we continue to assess the conscious state of a patient, and when they're sufficiently sedated, we'll insert an OPA and continue to pre-oxygenate with a bag valve mask. You know here that the nasal cannula remains in situ and still running at 15 litres per minute. The paralytic agent is then administered and we're right to progress towards intubation. The tip of the laryngoscope blade is then placed into the vallecula and the chin is lifted upwards and forwards, hopefully giving us good visualisation of the vocal folds. The bougie is then passed through the vocal folds under direct visualisation and advanced until it stops, and this will indicate that you are in fact in the trachea and not in the stomach. If you're in the stomach, it would just keep going. The tube is then passed over the bougie, still under direct visualisation, until the cuff extends a few centimetres beyond the vocal folds. The tube cuff is then inflated, and maintaining stabilisation with your hand, you'll attach the bag valve mask, which has your CO2 in line, and you'll confirm placement with end-tidal CO2 with a box waveform. You will then go on to confirm placement by auscultating the epigastrum first to ensure there's no bubbling sounds in the belly, which will indicate that the tube needs to be pulled straight out, and then auscultating both lungs. The tube is then secured and the patient is ventilated. It's important to keep a close eye on our end-tidal CO2 and our waveform capnography when we have someone who's intubated. This gives us a lot of clues about what's going on with their ventilation. Here we can see a nice box waveform that indicates the patient's ventilating well. All that's left to do now is just to maintain our anaesthesia and to avoid emergence. We like to keep the patient pain-free, repeat doses of paralytics if required, and certainly continued sedation so that there's no combativeness against that tube. And that concludes my second skill video on anaesthesia planning, RSI, ET, intubation and capnography.